So let's just think a little bit about what we understand now about the biology of acute myeloid leukemia. This is such an exciting disease for us to treat, because we're now getting really effective new treatment options coming through after a very long period of apparently not much progress. So what's been shown by next generation sequencing has been that there now are a number of genes that we reliably identify as being mutated in acute myeloid leukemia. And these are data from the Papa Manueli big study, in which she identifies about 13 genes that are commonly mutated in acute myeloid leukemia: FLT3, NPM1, DNMT3A, NRAS, CBP-alpha, TET2, WD1, IDH2, IDH1. Those are really the key players. And most patients with acute myeloid leukemia will have at least 2 or 3 mutations. And of course now some of these mutations are druggable, and we're going to talk about that in a minute. So that allows us now to be moving towards a definition of a risk stratification of acute myeloid leukemia that's not just based on cytogenetics, but increasingly involves distinct mutations. And the really important thing, of course, is that we can now use that mutational profile from next generation sequencing on the diagnostic sample to inform risk stratification. So this is the ELN 2017 risk stratification, and I think this is a really important advance in terms of thinking how we treat newly diagnosed fit patients with acute myeloid leukemia. You can see that we're no longer just using cytogenetics, but we have core binding factor leukemias, T821 in version 16, as good risk as before, but we now have patients with NPM1 mutants, about 30% of patients with AML, either without a FLT3 ITD or with a very low ratio, and also biallelic mutated CBP-alpha, who broadly do well with intensive chemo. And then we have a bunch of patients who, of course, have adverse karyotype, but also we can identify if you've got a mutation in TP53, ASXL1, or RUNX1, or you have an NPM1 mutation with a high FLT3, or you have a FLT3 without an NPM1, then you are now are unlikely to do well with intensive chemo. And then, of course, we've got a group of patients in the middle. So the reason this is important is because using that classification is a good predictor of how you will do with chemotherapy, and as we'll talk about at the end of this talk, really helps us choose which patients should be selected for transplant. So it's likely that as we get more molecular stratification, that as this data comes into our multidisciplinary team meeting, it's going to inform our decision-making in AML. So what are the recommendations around treatment of these different groups? Well, I think most centers are still using a 7+3 daunorubicin plus Ara-C induction. And it's really in the consolidation therapy, isn't it, in patients who get into complete remission, where we start thinking about the different options. So I don't think improvement in outcome in that population. There was some benefit in intermediate risk, but no benefit in adverse risk. So in the UK, we are using gemtuzumab in good risk and intermediate risk. In some countries, it's just used in good risk. CPX-351, I think, is a really important advance, and this is just a clever way of giving daunorubicin and cytosine ribonoside, but it's in a liposome. It's a 5-to-1 molar ratio, and treatments for older patients, should you give DA induction chemotherapy or an alternative agent? It's a very difficult decision, but I want to draw your attention to that the morbidity and mortality of DA induction chemotherapy is considerable, particularly in older patients. And there are certain factors that can predict for a high risk. Age over 75, poor performance status, complex karyotype, antecedent myelodysplasia, or a raised serum creatinine. And that's important to consider, because if you have 2 risk factors, your 8-week mortality can go up to 36%. So these are all individualized, personalized decisions. But when you see an older patient with AML, I think it's really important to be sure that they're fit before you proceed. And the second thing is, it is probably wise to wait for the cytogenetics unless you have to treat. It's very rare that you have to press on and treat immediately, because if they have a complex karyotype, well, you might either want to give them CPX or Vyxeos, or alternatively, you may wish, knowing that their outcome with 3+7 will be poor, to give them an alternative agent. So what are the drugs? Azacitidine, you will be aware, in a randomized study in patients not fit for intensive chemotherapy, had improved outcomes compared with low-dose Ara-C. We and the MD Anderson group separately have done large randomized studies looking to see whether you can improve the outcome of older patients with AML treated with azacitidine with an HDAC inhibitor. I could spend 20 minutes showing you the slides. I'm not going to. The answer is you can't. And I think people are rather disillusioned with pursuing this. There are 2 other drugs you should be aware of. A Hedgehog inhibitor called glasdegib. This is a pathway that's relevant in high-risk AML. And there's one randomized study showing improved outcome of glasdegib compared with low-dose Ara-C. That was enough to get licensing from the FDA, but I think it's fair to say that many of us are not yet persuaded that this is a really important new agent, and we're waiting for randomized studies that are being reported next year. The really interesting drug, of course, is venetoclax, a BCL2 inhibitor, and this is a drug that has developed through a long scientific history, and a lot of this work has been led by Andrew Way in Melbourne with great distinction. That monotherapy with venetoclax in AML was really rather unexciting in terms of results. But importantly, when you combine venetoclax with azacitidine, you get much higher CR rates, and in these retrospective studies, it appears you get better survival. The randomized study, Viali A, of venetoclax versus venetoclax plus Aza will be reported next year. It's also an interesting drug because if you give it with Ara-C, you get much higher CR rates, low-dose Ara-C, and you appear to get better survival. So the results of the Viali A study will also be reported next year. Suffice it to say that venetoclax looks like a game changer, but probably going to be particularly important in certain molecular subgroups. You can't quite see it here, but the patients who are doing particularly well are patients who are NPM1 positive, and also patients with IDH mutations. So it may well be that in younger adults with NPM1 mutations, there is a role for considering the use of venetoclax with azacitidine as opposed to 3+7. That's a big step. We're not there. We need randomized studies. But if you have such impressive data replicated in prospective studies, it may be that there are some groups who get 3+7 who we can move towards other therapies, but we need the randomized data. And finally, just to say TP53 is a bad player, isn't it, in AML? It's common in older AML, and there is an APR 246 agent, which is looking promising, but we need more data. So I just wanted to kind of close really by talking a bit about MRD. There are 2 or 3 ways, aren't there, to measure MRD. One is you can look at flow immunophenotypic characterization of an abnormal leukemia-associated cellular population. That can be done on all patients. Sensitivity is about 10 to the minus 3 or minus 4. Or you can do PCR quantitation, just like BCR-ABL, of specific transcripts, notably NPM1. Or you can, if you're very sophisticated, do next-generation sequencing-based MRD, which is actually much less sensitive. So these are the mutations that are amenable to PCR quantitation, NPM1 particularly. But the problem is that most patients over the age of, most adults don't have a suitable molecular marker. So at the moment we use flow, but it may be that combining flow with next generation sequencing based MRD is the way to go. That's not standard of care, but I just flag that up to you. So in my last couple of slides, I want to just deal with how do we decide who should go to transplant? I don't know about you, but I do my new patient clinic on a Monday afternoon, and these are still the hardest decisions. You have a 62-year-old or a 54-year-old with one comorbidity who walks into your clinic, and you have to try and make a decision about whether to take such a patient to transplant. And I agonize, I still agonize. I know what I should be doing, but it's still really difficult. And there are a number of reasons it's difficult, but I hope to just kind of walk through how we can kind of demystify it a bit, okay? So, all decisions are patient-specific. The rationale for taking somebody to transplant is because you think the increased anti-leukemic benefit of a transplant outweighs the risk. We're getting much better now at identifying how significant, how big the anti-leukemic benefit of transplant is. And I'll give you the bottom line, all right? If you have a transplant, compared with having intensive chemo, your risk of relapse is halved. The hazard ratio is, actually it's about 0.4. It's more than halved. And that is independent of the cytogenetics. We're also much better now, aren't we, about finding a donor, sibling, unrelated, cord, haplo. Most people have got a donor, but we're also, as I'm going to show you, much better at identifying the toxicity of transplant. So let's put all those together. This is the data showing that if you compare patients who have chemo on the left or transplant, the hazard ratio, the red bars, and look just at the bottom, the relapse risk is always halved or more, okay? At the same time, we know, don't we, if we've got a fit patient and we've got a good donor, that the transplant-related mortality in your unit, I'm sure, is the same as ours. I'd quote 15 to 20%, about 15% actually. So, this is easy, let's walk through it. If you have a patient with good risk cytogenetics, their risk of disease relapse, if treated with chemo, is about 35 to 40% if they're younger, all right? So if you transplant them, you're going to halve that. So that's a 20% reduction in relapse, and therefore a 20% reduction in death, we believe, because most people who relapse will go on to die. If you've got a transplant procedure that has a risk of 15 or 20%, it's really difficult to advocate a transplant in CR1. Easy. If you've got a patient with intermediate risk cytogenetics, think of them as they walk in and they're 50 and they've got intermediate, their likelihood of relapse, if treated with 3+7 and a couple of courses of chemo, well, it's at least 55%, it's probably 60%, it might be 65, okay? Do a transplant, do the maths. The reduction in risk of relapse is a half. So there's 30% benefit. So they go from a risk of relapse of 60% with chemo to 30% with transplant. A 30% benefit. Well, if you can do a transplant with a 15 or 20% risk to their life, probably nearer 15, they've got a clear survival benefit from going to transplant. If you've got a patient with bad risk cytogenetics, the risk of relapse on chemo is 80%, 85%. The benefit, halve that risk, it's down to 40%. The benefit is 40%. So if you can do a transplant with a 15 or 20% risk, happy days, but you might be prepared to take a slightly more compromised patient into a transplant because you might accept a higher TRM. So to do this, we're going to integrate the genomics to predict the risk of relapse if treated with chemo alone. We're going to integrate MRD that predicts risk of relapse. And we're going to use comorbidity scoring of patients to predict the risk of transplant-related mortality. In essence, if you're over 55 or 60 and you've got a comorbidity score of 2 or more, your risk of a transplant's pretty high. So my advice is if they're over 60, over 55, they should really have only 1 or 0 comorbidities before going to transplant. But actually, if you look at that population, they almost all have a risk of relapse of more than 60%, so most of them are transplant. In the younger populations, you simply have to ask yourself, what is the likelihood of their risk of relapse if treated with chemotherapy alone? And then you have to think about the risk of transplant. And I've shown you that it's very easy to do the maths, make the judgment.